This is going to be 60 minutes. What we're going to do, we have 2 articles to present. Dr. John Davitt and Heidi Kosarik will be presenting. Heidi is one of our statisticians here at Mayo Clinic, Arizona, and John is one of our fellows. And then we're going to ask questions after each article. People can comment. And then at the end, we'll have a comparison between the 2 articles. And then if we have time, we'll talk about some potential future research or research design and potentially some clinical considerations. So Heidi, as I mentioned, is the assistant head here of biostatistics at Mayo Clinic, Arizona, and her education is at Case Western Reserve, among other institutions. John was educated at Georgetown and Boston, among other institutions. And John, I'm going to go ahead and switch your slides, and we'll get started here, okay?
All right. Well, thank you for allowing me to present. The topic for the discussion this morning, and the topic of the 2 articles, is reoperation following surgery for stress urinary incontinence. We have no financial disclosures. The articles we selected were the efficacy of repeat midurethral sling for persistent or recurrent stress urinary incontinence, a Fellows Pelvic Research Network study. And this article is selected not only because it's from the recent Gold Journal, but also because a large number of the audience for these journal clubs really seems to be fellows, and we thought that this was a great article to highlight a study coming out of the Fellows Pelvic Research Network. And later on in the discussion, as we break down the study design and hopefully get a chance to talk about future articles, hopefully we can learn some lessons from it and build better studies as we move forward in the future. The other article was chosen due to a similar design. This one was the repeat synthetic midurethral sling procedure for women with recurrent stress urinary incontinence. This was originally published back in 2010 in the Journal of Urology. So to begin with, our first article here was put together by Dr. Smithling, Adams Piper, Tran, Dave, Chu, Chan, Antosh, and the senior author was Dr. Gutman. A little bit of background for this particular study is that stress urinary incontinence affects 45% of women in the U.S., and each year over 200,000 procedures are performed for stress urinary incontinence. The most common of that is a midurethral sling. And as the authors of the study highlight, even though the midurethral sling is an incredibly effective procedure, 23%, almost a quarter of these women who undergo midurethral sling, will have persistent or recurrent symptoms. Now, they highlight that the management of these symptoms can include more invasive procedures like a Birch urethropexy, can include urethral bulking agents, or repeat sling placement with or without removal of that original sling. And part of the reason they move forward with their study is that there's limited evidence on repeat sling placement, and the evidence that does exist is conflicting kind of at best about which route, retropubic or transobturator, provides the greatest benefit, the highest chance of success in these repeat procedures. So like I said, this was done through the Fellows Pelvic Research Network at 6 sites throughout the country, at MedStar Washington Hospital Center in Washington, D.C., at University of California, Irvine, University of Chicago, Northwestern, University of Pennsylvania, and Houston Methodist. So pretty large geographic area representing most of the regions of the country. They conducted the study as a retrospective cohort with a prospective patient survey. They identified their patients by CPT code 52788, which is a CPT code for sling revision. They selected patients between 2003 and 2016. And using these characteristics, they identified 188 patients, and they were able to contact and complete survey instruments with 122 of those patients. The survey instruments they used were the UDI-6 and the PGI-I. The average age of the patients they surveyed was between 59.5 plus or minus 12.5 years. And patients were excluded if they had an autologous sling, if there was a complication of the mesh itself, so pain, dyspareunia, mesh erosion, or if they were just unable to reach the patients by phone. In addition to this data, they abstracted information on BMI, patient demographics, the UDI-6 score, if it was present before the repeat sling, anticholinergic use, urodynamic testing, so a wide range of information about these patients. The primary outcome they selected was the proportion of successful repeat midurethral slings with retropubic compared to transobturator, and secondary outcomes of overall success, a determination of the optimal sequence of slings, and factors predictive of success for repeat midurethral sling. Based on previous studies, they found that they would need a sample size of 165 patients in each group required to meet 80% power. Now, they define success as a response of no to the UDI-6 question, do you usually experience urine leakage related to physical activity, coughing, or sneezing, and a response of very much or much better on the PGI-I. Their results showed that of all the slings placed, the initial sling heavily favored transobturator, with the retropubic mini sling and then an unrecorded sling route following behind. However, in the repeat sling group, the retropubic approach was heavily favored, with transobturator representing just over a quarter of the repeat slings that were placed. Now, within this group, they noted that 4 of their 6 institutions only placed transobturator slings during repeat procedures. They found that a mean follow-up duration after the repeat sling was 30.7 months. The initial sling was only excised in 13.9% of these patients, and they didn't find any association between removal of the initial sling and treatment success. And they found that the prevalence of intrinsic sphincter deficiency before repeat midurethral sling was 22.1 overall, and didn't differ between those who had a retropubic or a transobturator placed. Now, of those repeat slings that were performed, they found 67 patients met their criteria for a successful surgery. Of those 67 patients, 72 received a retropubic sling and 28% received a transobturator sling. Looking at their secondary outcomes, they found that the time to failure was 51.6 plus or minus 56 months. Overall, 55.8% of patients met the definition of success, and that's those 67 patients. Overall, 71.3 were very much or much better on their PGI-I. They found no significant difference in the composite success rates between the retropubic and transobturator, but as they highlight, they were unable to meet the required number of patients to actually draw this conclusion with significance. And they found that no particular initial route was associated with an increased rate of success in the subsequent sling placement. They did find that patients who received a repeat transobturator sling had more bothersome stress urinary incontinence. And they found that there are negative predictors of success judged by increasing scores on the UDI-6, specifically in question number 1 on frequency, 2 on urinary incontinence, 4 on a small amount of leakage, and 6 on pain. So as these scores went up, the chances of success with the repeat sling decreased. Now, they highlight that an issue with this can be that only 44 of their patients actually completed a UDI-6 prior to this repeat sling placement.
Sure. So as John already mentioned, the study required 165 patients in each group to have 80% power to detect a success rate of 60% for the transobturar and then 75% for the retropubic. And this power analysis was based on kind of some of the prior literature that was out there, giving a wide range of different success rates. But as he mentioned too, the study was significantly underpowered to detect this sort of difference and why they ended up getting a negative result. The analysis was appropriate given the study design, but however, as any retrospective design, it's limited in terms of we can't compare everything. There's lots of time trends because there was a wide range from 2003 to 2016 for this patient cohort. So there's a lot of variables that may or may not have been measured that we can actually look at. The prospective phone follow-up was conducted on that patient cohort. And this study, and I think I'll mention it later, but one of my concerns about this particular study was they only were able to contact 65% out of their, I think, 188 patients. They only had 122. So it's a bit concerning that they had sort of a smaller number of follow-up compared to the other study. And as I mentioned, there's lots of measured and unmeasured baseline characteristics of the patients that may differ between these two groups, and then also surgeon preferences or surgeon skills that may have impacted the success rates that we can't always measure in the statistics.
All right. So as we move in,
I think we're getting a little bit of feedback. If you could mute your mics, please. Thank you.
So to sum up this study, the overall success rate of the repeat slings was found to be 56% with no difference between retropubic and transobturator, although, again, they didn't quite meet their sample required. The strengths of the study were its multi-center design, that it did include a prospective component. The challenges they faced were that certainly not all of the patients that they surveyed actually completed a UDI-6 after their initial sling and before the repeat sling to allow for evaluation of improvements once the second sling had been placed. The challenges inherent in a retrospective design and the bias that introduced, and the fact that there was no objective measure of stress urinary incontinence relief following that mid-urethral sling. They really were reliant on surveys and patients' experiences with their repeat slings.
Why don't we open it up to discussion and on either of the people joining us by online or in other Mayo sites? Any commentary?
Hi, this is Manuel calling, asking a few questions from Rochester. How are you guys doing?
Good morning.
Thanks for joining.
My pleasure. I was just wondering, they come up with this number of 188, but we don't have a denominator. Do we know how many total patients were eligible for the study, or that's not clear?
No,
188, I think, are eligible based on their CPT criteria, searching over the years that they picked, 2003 to 2016.
Okay, so out of those, however many 1,200, 1,600 patients, only 188 met inclusion criteria, correct?
I believe so. I mean, that's how I read the paper, but.
And I'm wondering what your thoughts are about selection bias. In particular, that there were surgeons that all that they did was transobturator slings. And the other concern I have, as well as time to event, right? At least the way I think about a failure, there's two potential different reasons. You can fail because the first procedure was done not well, right, as a technical failure, versus somebody who had a good success and over time that procedure waned. And there's nothing in this paper that can separate the two approaches. And over such a huge time frame, to look at proportions really limits the evaluation of their outcomes, because there's people who are in the study for 10 years and people who are in the study for a few months. And there's nowhere in the analysis that we can sort that out. And the last comment I'll make is looking at concomitant surgeries is a really big factor, because the study we just published shows that a transobturator sling fails much, much higher if it's combined with a prolapse repair than if done alone. So I think some of these issues, I think, make interpretation of the study a little bit limited. I was just wondering your thoughts.
Certainly. So the number of patients that they were able to capture, I think is the kind of the largest that's in the literature, but right, they were able to do that only by looking over this huge swath of time, where the time to follow up certainly is anything from a few months to years. And so for what they were, for the number of patients they were trying to capture, it seemed to kind of be the best that was possible. But certainly they sacrificed some of those more detailed analyses in order to capture a larger sample of patients.
And certainly they could have looked at time to event and looking and doing, essentially survival statistics and time to event for failure. I think that, I'm not sure why they didn't do that, but I don't know that it would have necessarily shown anything different, just given that they were significantly underpowered for this sample size.
And the last thing I will say is we haven't published this yet, but be leery of looking for objective outcomes in stress incontinence studies. We looked at a correlation between like 20 different stress incontinence outcomes and correlation to patient perception of improvement and surgical success. And we looked essentially at this Cohen D value that looks at really differences between successes and failures. And the more objective, the more stringent the criteria, the less it correlated with patient perception of improvement and success. So if you do something like ICIQ less than 5, it was much better than composite with negative Croft stress test, score equals to 0. So it seems like the more stringent you became, the further away you went from patients being happy with the outcome and differentiating success and failure. Just as a comment.
For those signing in on their computers, more comments?
We can mute.
Manuel, you mentioned selection bias. I think one thing that can ameliorate that arguably is that there's 21 studies comparing TOT and retropubic, and overall they show no difference in terms of success. So one could argue there could be some amelioration because of that comparison being fairly equal in terms of stress outcomes. Well, let's go on to our next paper.
So our next study is repeat synthetic midurethral sling procedure for women with recurrent stress urinary incontinence. And this was conducted by Dr. Staub, Dwyer, Rosamilia, Sherlitz, Lim, Chow, Souza, Thomas, Murray, Conway, and Lee. Again, this was published in the Journal of Urology in 2010. And this study was taken from a population in Australia, and the rates of urinary incontinence in Australia that it affects about 37% of women. And again, the most common procedure for treatment of stress urinary incontinence is midurethral sling. This study also looked at a retrospective cohort of 1,225 women who were identified as having undergone midurethral sling placement from May of 1999 through August of 2007. Of all of these patients, 1,112 were able to be reached and completed the study questionnaire. The average age of these women was 60 plus or minus 12.9 years. And the patients were interviewed with a standardized questionnaire that the study group developed based on a composite of questions selected from other validated instruments such as the UDI, PFDI, POP, and UIS. In addition, their assessment collected demographic information, medical history, lower urinary tract symptoms, physical exam, bladder diary, urodynamics, and surgical reports. The patients who were not included in the study population were those who were unable to be reached due to death or change of address. The outcomes they selected were a subjective cure, the evaluation of perioperative morbidity, and then an evaluation of long-term outcomes. In this study, they defined success as no further continence surgery and those who responded no to the question of leaking urine during physical activity, coughing, or sneezing. The route of sling placement across all patients heavily favored the retropubic route, with only 22% receiving a transobturator sling. And they note that the sling placement was elected solely based on surgeon preference. The results, they found that of their 1,112 patients, 77 received a repeat mid-urethral sling, and 1,035 had a primary sling placed. No slings were removed in the repeat group, and the overall continence rate was 73%. The overall subjective cure rate was 86% for a primary sling placement and 62% for a repeat. The average time they found between a primary and a repeat sling was 2.1 years, plus or minus 6 months. And 94% of their primary group and 81% of the repeat group did respond yes to the question of, would you recommend this operation to somebody else with incontinence? So just to recall, they defined success as no further continence surgery and responded no to the question of leaking urine during physical activity. In addition to these results, they found that those in the repeat group had a higher rate of intrinsic sphincter deficiency and a lower minimum urethral closing pressure. Patients who underwent repeat sling had significantly higher subjective cure rates in the retropubic group than the transobturator. So that brings us here. So 34 of the 48 patients who underwent repeat retropubic sling reported success or met their definition of success. And 14 of the 29 patients who underwent a repeat transobturator sling met their definition of success. They found that in these groups, the type of primary sling had no significant impact on the success of the repeat sling. And looking at some of their other outcomes for perioperative morbidity, highlighted a few here and just kind of blown those up so that we can see them a little bit easier. But they found that in the repeat group, there was a statistically significant increase in de novo urgency and de novo urge urinary incontinence. But between these two groups, the repeat and the primary, there was no significant difference in days hospitalized, in dyspareunia, de novo voiding difficulty, or perforation.
So again, this was a retrospective design from the years of 99 through 2000 with similar phone follow-up to the other study. One of the things that I do commend them for is that they had a very high response rate of reaching these patients, 91%, as compared to the other paper of only 65%. Their main outcome was the success rate between the primary and the recurrent disease. And then they did some of these subgroup analyses, looking at the repeat slings by the different methods. And in that case, they would have limited power to detect differences for these subgroup analysis, but in the case of looking at the two different methodologies for the repeat group, they did actually find a difference. They do mention in both these studies, that the confirmation of these findings would need to be examined in a well-designed prospective study with, enrolling patients prospectively, following them, getting the same outcome measures at various time points, and it's probably not feasible, but could a randomized clinical trial actually be conducted in this type of setting, where you would actually randomize patients to get the two different methodologies for the slings.
And so to summarize, the strengths of the study are that it does contain a prospective component with a large response rate to their survey. There's a large number of patients within the study's context. So when this was conducted in 2010, this was the largest group of patients who had undergone repeat midurethral sling that had been evaluated. And in this study, they highlight that all of their patients undergo standardized collection of preoperative data regarding their symptoms. The challenges of the study certainly came from the retrospective nature of a large portion of the data they collected. And again, that there was no objective measure of success, although we might question exactly how to evaluate that and whether that's meaningful in these studies.
So one of the things that when I look at these two studies is like, well, are they conflicting? Do they give us kind of the same, outcome measures? And so I just kind of put this table together. And so as you look at the two papers, some of the differences that may account for some of the different success rates that we see is I already highlighted, kind of the differences in the follow-up rate, 91% versus a 65%. They did use slightly different definitions of success between these two studies, so that may be partly why the success rate differed. The Smithling authors do mention that they did sort of a sensitivity analysis and they used this paper definitions for success, and if they did that, they would get rates of 66% and 63% for their two methods. So kind of in the same ballpark. So I think for the most part that while the success rate numbers might differ a little bit, I think that they're both kind of giving us similar information of, where the success rate might fall, particularly in the repeat group, anywhere between 50% all the way up to 75 or all the way up to 70%.
All right, questions if you're signing in on your computer, commentary and questions?
Hey, this is Tom Gregory. Can you guys hear me?
Yes.
Yes.
I'm so sorry that I don't know what was going on my side. I apologize for being tardy. But I was wondering if somebody could go back and kind of spend some time on table 3, because I read it multiple times and looked at it, and I was really having a hard time with this article, understanding exactly what was going on there. It seems like basically it's suggesting if you had a previous transobturator and had a repeat, this was your success rate. And if you had a previous retropubic and then had a repeat, this was your success rate. But I have to say I'm not exactly sure that I'm interpreting it right.
Heidi, how do you interpret that table?
So I think in this table, they're just looking at those who had a success and then those who had a failure. And they
In the repeat section or in the primary?
This is just in the repeat group.
Right.
So there should only be, I think, 77 patients. So they had 48 successes and 29 failures. So they looked at some various patient demographics to see who might be a success versus a failure. And the only thing that came of significance was what kind of sling type they got. So again, the retropubic. So that's where they're getting the 71% and the 48%.
Did they not go through at some point there, though? It said, hey, if you had a previous, so if you're in this failure group and you had a previous transobturator and then you had a subsequent transobturator, your success rate was X or Y.
I don't know if they actually did that. Do you remember, John, if they looked at what the prior one was? I think they mention it in terms of the patient demographics, but I don't know that they actually.
I think maybe
I
the
guess I'm just
post-comment.
thinking about in the discussion, they have this paragraph about, they talk about the urodynamic findings and stuff like that, and they say, interestingly, despite having a higher incidence of intrinsic sphincter deficiency and lower mean, closure pressures, patients who underwent a repeat retropubic midurethral sling, which to me suggests that they had a previous retropubic midurethral sling, but maybe I'm over-interpreting it. Had a higher subjective cure rate than those who had a repeat transobturator group, 71 versus 48%. But I think that is exactly what this table suggests, and I'm finding myself now, as I talk, kind of perhaps having over-interpreted it.
Yeah.
So in the results, they do mention the subjective cure rates of repeat after a failed retropubic versus a failed obturator were 67 and 74%. Of course, not difference. And then
Right.
suggestive cure
Okay.
rate of repeat transobturator after failed retropubic and failed obturator were 53 and 40%.
Right.
20, but none of those subgroup analyses are significant, which I wouldn't expect
Based
them
on
to be.
sample size, for sure.
Yeah. So they sort of look at it, but knowing that they're probably not going to find any differences there.
Additional comments? Why don't we ask those in attendance, just in terms of their clinical thoughts, if they were doing a repeat sling, regardless of the primary sling route, would they prefer to go retropubic or transobturator route? Let's just take a little survey. Tom, what would you do?
I'd do retropubic. I've seen people
Others?
say the same thing here online too.
I would do the same.
I agree.
Same here.
I do think it's interesting, though, in the Smithling study, you have to see that it says the second sling was 76% retropubic and like 25% transobturator. 4 of the sites did transobturator only, which means that 2 of the sites collected most of the patients. I think even just polling us, most of us would do retropubic. But the 2 papers do say that the decision of what kind of sling was done was based on surgeon preference. And at least from the evidence that we have, although this was
Biased.
unpowered, I don't think that we have that as an evidence-based recommendation. I think we still have that as a surgeon preference because we're not seeing a difference that there. I guess in this paper it does show that the retropubic was higher. That was one significant finding in the urology paper. But in the Smithling paper, we can't really say. So I think that's still based on surgeon preference.
I think the strength of the Smithling paper is it becomes a descriptive study that just gives us the numbers on success with a repeat surgery. And as the 2010 authors pointed out, this has to be done prospectively.
Yeah, I was gonna, but I signed on too late. But actually, at this point in the conversation, and with the biostatistician expertise in the room, this is actually an interesting sort of, if you're looking at study design, the Smithling paper, while it's got, in name a retrospective cohort with a prospective piece to it, it actually starts the clock at the moment of identifying these repeat surgical procedures and looking back in time for covariates and looking forward for like outcomes. Whereas the Stav paper sort of is the prospectively from the initial surgery and following them through time. So you get just a different flow of subjects with a little bit different flavor as to what happens. Also, of course, 2 different time periods that they're looking at, which can affect obviously the expectations of success rates and the sample size. So it's just an interesting sort of, if you're trying to redesign a study here, assuming that you're not necessarily going to do the actual prospective study that they're talking about, looking at these 2 designs is really intriguing as you sort of think through about what your interpretations are.
I have a clinical question because I don't do these operations anymore, but when I did do them, if it failed, and it's just a few that I can remember, I always did an autologous sling. Is that not something that's done anymore, or do you go straight to repeat?
I think it's still an option. I think it depends. This is Chris Walter. I'm a urologist here at Mayo Clinic, Arizona. I think it depends on patient preference. There's a lot of stigma with mesh, of course. The other thing is, if you're planning on removing the sling, then I would probably lean more towards autologous. I think because you're going to, by necessity, perform a urethrolysis, and I think it'd probably be more lending itself to an autologous placement then.
It seems like, at least current practice, seems like recurrent mid-urethral sling is probably most most common practice. So two failed slings before an autologous sling. I mean, that's kind of how I think of it, but I'm not sure if that's.
Does that old mesh get in the way of trying to do the same repeat retropubic sling again?
Not from the ones that I've done. I don't know if you've.
Yeah, but sometimes it's really hard to find it, period.
Yeah.
And if it is there, it's not always in an ideal position, I guess I would say. That might lend itself to why it failed as well.
Anita,
Yeah,
in
location-
Florida.
Go ahead, Anita.
I was just curious to see how many in the audience would offer a bulking agent procedure prior to another sling for recurrent or persistent incontinence.
Depends on their urethral mobility and their closure pressures. Huh?
Yeah.
I would, but I think the other thing that we can talk about in a few minutes is the idea of what Willie Davila did in terms of looking at ultrasound assessment of the slings. So a sling has failed. Why is that? And then does the patient have obstruction? So I'm going to show you an article in just a little bit that where they took out the old slings, and about 9 of the cohort that they took out had obstruction or voiding dysfunction. So I think, looking where the sling is, palpating it, if it's a urethrovesical junction, do they have obstruction? Did their bladder overactivity or de novo incontinence increase? That may make you more likely to take out the old sling and then not do a bulking, but rather go to a repeat sling. Additional questions on these 2 articles from those that have signed in on their computers?
I have a question for the group because this finding was a little bit unexpected, as Chris and I were talking about, that there was more urge incontinence in the transobturator group after the repeat sling, right? They had more anticholinergic use after the transobturator sling, I think it said, for the repeat. In the second sling, yeah. Which they explained by saying that they may have had more underlying urge incontinence or overactive bladder. That's why they got the transobturator sling. But I don't see that in the data that they present. I don't see that in the data that they present. Anticholinergic use before repeat sling or detrusor overactivity. Data that they present, so I'm not sure that that's actually shown in the data, but it makes sense what they're saying. So I'm just wondering because it was surprising because you'd think that the retropubic would have more overactive symptoms afterwards. Any comments?
I guess this is Tom Gregory. I think that that is another one of those questions about surgeon bias. Some of my colleagues who do more transobturator techniques will choose to do it that way to obviate against the potential de novo urgency incontinence or urinary retention question. I think part of it is that way. And so is it possible that given we don't have this information, did they have a bias toward the transobturator based on this worry preoperatively that then sort of manifests itself postoperatively?
One of the, when we had considered the two papers for the Journal Club, one of the papers that we had considered was Emmanuel's paper. And Emmanuel, I just want to see if you have any additional commentary on your paper.
Dr. Trabucco had to run to the operating room, so I'm sorry he's not here
Okay.
anymore.
All right, well, I'll show a video of it, or a slide of it in just a second here. Additional questions or comments?
Just to Tom's last point, we're just not going to be able to escape bias with these two study designs.
Right.
That's what we're stuck in. So.
So what ideas do people have in terms of future research?
Well, number one is, collecting the data prospectively enhances the quality of the data that you garner. And I think going back into charts, one of the questions I had with the staff paper is, how do you really know if someone has a repeat, or I should say, if everyone in the primary group did not have a repeat?
Right.
Because you have to rely on the patient history as they come into the clinic. And for all we know, there could have been a pretty large percentage of people who had a failed sling at another institution. So that's one thing. And again, that has to do with the retrospective nature of both studies. That type of error is going to be prevalent throughout the analysis. The other thing is, can you really do a randomized controlled trial? Yes, but it takes a lot more resources and a lot more patience to find these subtle differences. So at this point, if a single institution, for example, or even like a fellows research network just followed prospectively over a 10-year period, you're probably going to capture 10, 20% of repeat slings in that population. Plus place and time. Tom made the point that one study was about 5 years earlier than the other study, and all of us hopefully are getting better at these procedures as time goes. So perhaps the differences between your retropubic and my transobturator or something like that are being ironed out as clinicians are just becoming better at both procedures and teaching them as well. And the last thing I would say is that you're going to find higher transobturator sling percentages at teaching institutions. That's another thing that's kind of coming from the data. Just a couple of general points. I mean, I take all of this with a grain of salt, and it just becomes very much descriptive studies that just gives us numbers on perhaps what we tell patients when they're coming in for a repeat procedure, and leaning us towards retropubic slings instead of obturator slings is sort of the mist of the take-home points here.
Mm-hmm.
Thank you, Steve. Additional comments?
And so I know here when we were talking about building study designs, kind of around answering some of these questions, certainly the idea of prospectively collecting data came up, but another one that was entertained was the institution of some of these standardized elements as part of the preoperative planning on just a routine basis. So I'd be interested to know, if anybody else uses any of these survey elements as part of their pre-op preparation to create a database at their own institution that could then be revisited in the future to see some of these outcomes a little bit better.
Comments?
This is Akriti in Florida. We don't use these particular survey instruments, but I think in a lot of different research projects, they're very useful in seeing kind of the patient experience and subjective findings that can be very useful in research. And we've actually met with the patient-reported outcomes team here in Florida, and they're actually pretty easy to assign to patients in Epic. So I think that if this is something that you all are interested in doing, it's very useful. And then you can start, again, like you said, building your own database that can be used, 5, 10 years down the line once you've collected quite a bit of information.
Very good. Steve, do you see that blue slide there, comparisons and future research?
Yes.
Okay. We just have a few more minutes. I thought I would just make a couple clinical points here. Emmanuel left, but we were considering his article, which was reoperation for urinary incontinence after retropubic and TOT procedures. That was a retrospective cohort of about 1,800 women, of which the majority were retropubic procedures. It was actually Uritex, probably. The TOT had an increased risk of reoperation for recurrent USI compared to retropubic in his study. Just some clinical considerations to think about. Paul mentioned hypermobility, and I think that's very important in terms of when people, a couple of the articles mentioned ISD, and of course there's no definite definition for ISD. It used to be a bigger thing when there were not the transvaginal tape procedures and people did autologous slings versus bridge procedures. But I think there's still some important elements missed when people don't think of hypermobility in the definition. And we know that even going back all the way to Olmston's data, which is in this slide. So this is the Olmston group that came up with the TVT. Razapor reported this article, TVT in patients with intrinsic sphincteric deficiency, and they broke it down, and there was a 14% failure rate. But when you looked at their paper and you looked at the patients who had immobility, 8 failed. So I think that, when you look at the patient with recurrent incontinence, if they don't have UVJ descent, that's probably not a good patient for a repeat sling. And likewise, when you're considering a primary sling, it's not a good idea if they don't have mobility. So we would say ISD, in our opinion, would be no urethral junction descent, patient has immediate non-sustained urinary leakage without bladder overactivity. The other thing I mentioned earlier was this idea of somebody comes in and they have a sling. I just saw a patient recently, it was quite a case. She had a sling somewhere in Phoenix, and it was at the UVJ, and she actually had complete bladder emptying twice during our consultation. She could not void, she was obstructed, and unfortunately that obstructed nature, because of the time that passed, resulted in permanent changes of her muscle. But because the sling was at the UVJ, we took out the sling. She was then able to void, but she was left with the muscle damage of bladder activity, which she just got a interstim after failing medication and Botox. So I think where the sling is, we used to put normal slings at the UVJ, but for some reason transvaginal tape procedures don't do well at the UVJ. So one question you should ask prior to repeat sling is, where is the sling? Is it at the UVJ? Do I want to take out that vaginal aspect of the sling before doing a repeat sling, or other measures? I mentioned there was one article looking at repeat synthetic, this is on ISD. This is actually from the paper we did. And just to illustrate, their definition was max urethral closure pressure under 20, or a leak point pressure of 60 or less, but they don't mention mobility, and that's where I think that we should be looking at mobility and mentioning that in our papers and in our notes when we see patients. This was a concurrent midurethral sling excision or lysis at the time of a repeat sling. This was done by Steele, Unger, and was published in the Internal Urogyn Journal. It was a retrospective cohort in 2018. 61 patients, and 28% of the cohort underwent lysis or excision. And then when they broke down the reasons for excision, about 9 patients had voiding dysfunction or bladder overactivity, and there was another group that was similar that had a couple patients. So I think that when they say in the small cohort concomitant excision did not improve outcomes, it may be dependent on where the sling actually is. Is it at the UVJ? Do they have obstruction? How much de novo bladder overactivity do they have following the repeat sling procedure? So that was just a couple clinical comments. Anybody else have any additional thoughts?
I like, Jeff, how you brought all that together, and certainly those are like the subtleties in choosing TOT versus retropubic. And these studies, kind of in the spirit of the studies, they're kind of glossing over all of that. That's what's also missed as far as the mobility, the presence of ISD, because again, the retrospective surgeons were biasing themselves at the time to either or back then, and also basing their repeat sling to be largely retropubic was also based on perhaps a bias that we have yet to uncover.
I think your idea of prospective data and hopefully database is so important because these are just the kind of issues that we're probably not going to learn about unless we do that. So that's a great point. Additional comments? All right, well, I'd like to thank everybody for attending. Steve, thank you. Tom, Veronica, and all those connected by computer. Thank you very much. Have a good day.
Thanks a lot. That was great. I appreciate it. Bye,
Thanks so much.
That's for our first. Thank you for inviting me.
Thank you, John. Thank you. Thank you, Heidi.
Oh,
Good
you're
job.
Like all your map of the U.S. and like I was like, it's like so simple, but yet so like, yeah, this is many, you know. Yeah, no, it's
lists
it's
of
all
numbers.
text. Yeah, people just
Thank you for taking the time to come
Oh,
over and
anytime.
for helping us with this
Yeah,
drill.
no
That was-
problem.
we're so
Anytime, I'm
appreciative.
happy to do it.
Your conference is scheduled to end in 2 minutes.
Your technology worked pretty well.
Yeah.
It's always sort of like.
Last week I was going through this and because the Mayo Clinic has a firewall, so we can't sign into somebody else's Zoom. We have to create our own Zoom. So that was kind of a little thing I went through there.
I can
Yeah.
reach upstairs because I'm gonna have to go change too. Oh yeah, go for it. Get breakfast if you have.
I don't know how many people were signed in there.
I know.
Hope there was not a problem.
Thank you.
Good job. Thanks a lot.
Your conference is now over. Goodbye.